This study was in patients with unresectable stage 3 non-small cell lung cancer, and those patients all received standard of care chemotherapy and radiation concurrently, and then were all placed in our study on consolidation pembrolizumab, which they received every 3 weeks for up to 1 year. And what we looked at mainly was time to distant metastatic disease or death. We also looked at progression-free survival, overall survival. We certainly wanted to look at the toxicity of adding a checkpoint inhibitor after chemotherapy and radiation. What we saw in this study was the addition of pembrolizumab after concurrent chemoradiation improves the time to distant metastatic disease or death. In our trial, we saw a time to distant metastatic disease or death of approximately 22 months. The historical control has been considerably less than that. The most notable recent study to look at that would be the placebo arm of the Pacific trial, where their time to distant metastatic disease or death was around 14 months, so approximately an 8-month improvement. We also see improved progression-free survival, both at the median progression-free survival and also at 12 and 18 months. The overall survival estimates for our trial look very promising, though the data is not quite mature enough to make a lot of definitive conclusions about that. We have 2 trials now that confirm the strategy, but I think the question really is, how do we choose which patients benefit and which ones don't? Immune therapy has toxicity, sometimes very severe toxicity. It certainly is very expensive, so choosing which patients will benefit and which ones won't is a really key question for the future. The other question is, while we do see a substantial improvement in outcomes in this study, how do we improve that further? There were a lot of patients that still weren't cured with this regimen, so how do we get to the point where we're curing even more patients or improving the time to progression for more of our patients? And that could be from the addition of other medications, it could be from a better choice, it could be from improvement in chemotherapy or radiation techniques. This really confirms a change to the standard of care for these patients. This is a patient population who, despite numerous studies over the last 2 decades, has really done fairly poorly in terms of overall outcomes. The Pacific trial, which was published in the fall of last year, looked at a different medication, but with a similar approach, and they showed a really substantial improvement in progression-free survival in those patients. What's exciting about our trial is our trial confirms that approach does work, just like the Pacific trial did, and in some ways gives some of the first hints that we may be seeing an overall survival benefit to these patients. So I think this affirms their trial, but also offers a new hope to patients with stage 3 lung cancer that, they may have higher rates of cure than we had seen at any time in the last 2 to 3 decades.